Dr. Satyavani. Thank you. I will start sharing my screen. Very good evening, and thank you, Endocrine Society of India, and especially Dr. Ganapati and Dr. Satyavani and rest of the Dr. Kaldra for all this wonderful organizing many programs. And thank you, my senior faculty, my senior colleague Dr. Prasad, Professor Vinod, and all the other members in this podium. Next few minutes, I would like to go through insights which we gained in Vellore over last 1 decade with regards to dealing with osteoporosis in elderly, starting from epidemiology, diagnosis, and treatment. So when you look at osteoporosis per se, this is a large study, 1,500 rural women in and around Vellore. 50% have osteoporosis. As the age advances, the prevalence also increase. This is the study from urban part of our Vellore. Once again, 50% have osteoporosis. In men, we found that about 20% of men above 60 years have osteoporosis. What about fractures? This is a recent study. 70 years and above, at least 15% have one vertebral prevalent fracture. So what? What about the vertebral fractures in women? This is on a large number of 400 women from postmenopausal women above 60 years. At least 1/3 have at least one prevalent fracture. And we also looked at the mortality in people, women, elderly women attaining or sustaining femoral neck fracture. We found that 20% die within 1 year, irrespective of what we do. Now, in spite of all this, the knowledge among women, postmenopausal women and elderly women about osteoporosis is suboptimal. Not only that, among physicians, we found that the knowledge about awareness for treating osteoporosis has been suboptimal. Now, there are so many risk factors Dr. Amit has mentioned, which are modifiable as well as non-modifiable in Indian setting or global setting, like modifiable like vision, fall prevention, vitamin D deficiency, dietary calcium intake. There are non-modifiable factors like family history, age, which we cannot modify as a risk factor for osteoporosis and fracture. Now we know the gold standard for diagnosing osteoporosis in India, global setting is DEXA scan. We take a T-score cutoff of less than or equal to -2.5 at lumbar spine or hip or femoral neck for diagnosing osteoporosis. Of course, when we talk about DEXA scan, always there is a debate which database to use. We have looked at this, looking at the ICMR database as a reference for diagnosing osteoporosis, North Indian database. We found that North Indian database we use as a reference, we had a precise diagnosis of osteoporosis even in subjects with prevalent hip fracture. Now, we all know that DEXA scans are limited, 800 scans for a people of 150 million elderly people at risk in India. So we have to find alternative. Now, this is a simple study done in Vellore by medical students along with Nitin, looking at the teeth and osteoporosis. The people who had 3 teeth loss or more had a higher risk of osteoporosis compared to people who had a teeth loss of less than 3. There are other various clinical risk factors like age, weight. All this can be utilized in making screening tool for osteoporosis. One such tool is OSTA, osteoporosis self-assessment tool in Asian. It has been validated in a large cohort population from our center in elderly women as well as elderly men. OSTA is easy to calculate, 0.2 multiplied by weight minus age. If somebody gets a score of less than or equal to -1, they are at high risk for osteoporosis. Now, this is an online tool available in we can use it on a smartphone. It's there for last 10 to 15 years. We can use an Indian flag, various risk factors. We have to say yes or no. In the OPD, we can use it without BMD. Recently, we validated this in a cohort of postmenopausal women with the prevalent vertebral fractures. We can use a cutoff of 9 or above for a major osteoporotic fracture. If you tap it into fracs, we get a risk factor for a major osteoporotic fracture as well as hip fracture. If a cutoff is more than 9, we can start treatment. Now, if you look at in this population, basic investigations, if possible, fasting calcium and phosphorus, albumin and renal parameters. If facilities are available, cost is not a constraint. We advise 25-hydroxy-D and PTH and bone turnover marker. In many settings, X-ray lateral spine can be done to look at a vertebral height for prevalent fractures. Of course, as I mentioned, DEXA scan can be used for a BMD. Of course, DEXA scan, of course, all the latest scans have VFA assessment, microarchitectural deterioration assessment like a TBS, hip geometry assessment like hip structural analysis. Now, when we are interpreting DEXA scan in elderly, we have to be cautious. This was a 90-year-old lady with a back pain, sustained a lumbar spine fracture. BMD was falsely high. When we looked at the lateral X-ray, you can see very clearly there was an aortic calcification. That is the reason BMD was falsely high. And we have to be very careful in interpreting. When we did a lateral DEXA, you can see it was grossly negative. Now, in elderly population, when we talk about osteoporosis, we have to always keep in mind malignancies, endocrine conditions, medications like glucocorticoid. We have to keep in mind when we are looking at a differential diagnosis for osteoporosis, like hyperparathyroidism, Cushing syndrome, cortisol excess state, etc. Now, these are the adjuncts which we can use. Trabecular bone score, microarchitecture, we can this as a part of DEXA. Looking at a hip geometry, we regularly use for additional assessment in elderly population for a fragility risk, fracture risk. Now, this is a study we published recently, how the diabetes is different. Diabetes is one of the common comorbid condition in Indian setting. We all know in diabetes, BMD can be falsely high and we can underdiagnose osteoporosis. But here, trabecular bone score is available. It may fetch more diagnosis of bone fragility over BMD. This is what we published recently. That is TBS fares better than BMD. Of course, there is no regular guideline. We all know in most part of India, the calcium intake is poor, except in states like Punjab, Gujarat. So this is a study from our part. Majority have a poor dietary calcium intake. This is a study which published last year, looking at 96,000 people, and the fracture risk was the vitamin D deficiency was about 50%. And this is a recent menopause society guidelines. We are also ISBMR, Indian Society Bone Research Guideline. We advise calcium for all elderly women and men, 500 to 1000 milligram, preferably calcium carbonate. Patient has got an acid peptic disease, we can use calcium citrate. Now, regarding vitamin D, we have our own guidelines. Many of them are deficient. We recommend all women to have, all elderly men to have vitamin D cholecalciferol 60,000 units once a month or once in 2 months. So we have to be aware we shouldn't overuse parenteral preparation of vitamin D, where we may get vitamin D intoxication. Otherwise, in a regular use, oral use, 1,000 to 2,000 units every day till death cannot cause any problem. Now, of course, in elderly population, we have to be concerned about all these fall prevention measures. Now, coming to the calcium, in addition to calcium and vitamin D, we talk about bisphosphonate. That is the first line of choice, alendronate, soldronate, and this is an anti-resorptive. In somebody has got a kidney disease, we can use anti-resorptive denosumab, 60 milligram subcutaneously every 6 months. Especially the problem with denosumab is it's costly, 16 to 18,000 every 6 months. In somebody has got a very severe osteoporosis, multiple vertebral fractures, we can use bond forming agent like Caryparatide. We can use, of course, the newer agents like Caryparatide and romosozumab are not yet available in India. So this is a study, the first study from India we published from our center, looking at bisphosphonate use and BMD and fractures, did well. Regarding Caryparatide, this is a recent study from our center, looking at the BMD improvement and reduction in the incidence of incidence of fractures. It did very well. So all these agents work well in the Indian setting. So recently, last week, we have our Indian Society of Indian Society of Bone Medicine position statement. Somebody has got multiple fractures, prevalent fractures, preferable to start with anabolic agent Caryparatide. Somebody has got a prevalent hip fracture, soldronic acid may fare better. Somebody has got a very high risk for fracture, we start with IV bisphosphonate, then comes the next option will be oral bisphosphonate. On follow-up, we can use the bone turnover marker. We all know bone is a dynamic tissue. We can use bone turnover marker as the two bone turnover marker in the blood we can measure is a bone resorption marker CTX and bone formation marker P1NP. We have derived in our part of a country ethnicity specific cutoff we have, which we can utilize for follow-up of patients on anti-osteoporotic treatment. Now, I like to conclude, osteoporosis is a significant problem in elderly Indian population. Many risk factors like decreased vision, falls, precipitating falls, all these are potentially correctable. Screening tools like OSTA can be used in a community setting. FRAX can be used in a community setting. Physical activity, diet, calcium, and vitamin D, as well as anti-resorptive or anabolic agent can be utilized to prevent fragility fractures. Thank you very much. And we have to give dignity, we have to respect these elderly people, and we have to take care of them. Thank you very much.